It is very nice to meet you again on this pleasant event. Good morning, good evening, good afternoon to everyone from where you are. It's my pleasure to welcome you to the special webinar of Global Alliance for Medical Physics Education and Research, which is held in celebration of World Radiotherapy Awareness Day. I will introduce myself. I am Maya Topeshashvili. I am Chief Medical Physicist of Radiation Oncology Department at Stodua Clinic in Tbilisi, Georgia, and also an executive member of GAMPER. Dr. Jubairul Islam, founder and executive director of GAMPER, gave me this privilege to host today's webinar. We know that World Radiotherapy Awareness Day was celebrated on the 7th of September this year, and this day was chosen to commemorate the first patient treated on linear accelerator. It was a very interesting fact for me because as a medical physicist, from the history of radiotherapy, I knew that first patient was treated in 1956. It was a small child of retinoblastoma. It was in January, but today, with our respectful special guests, these are Dr. Katie Bakam and co-chair of, co-chair of World Radiotherapy Awareness Day, and Dr. Jubairul Islam, founder and executive director of GAMPER. They will introduce us and will definitely speak in more details about the history of the event, about the importance and of its initiatives. Today's event, as all previous events, was organized by GAMPER and made possible through the collaborative efforts of professionals across different regions. And of course, it is held through the great effort of team and founders of GAMPER. So I want here to express my great respect and say thanks to all of them for giving me and us these possibilities. I am pleased also to mention regarding the tremendous global response of this event. Today's session has over 1,000 registered participants from all countries worldwide, for many countries worldwide, and this audience includes all professionals, radiation oncologists, medical physicists, dosimetrists, radiologists, radiation therapists, researchers. This means that the number of professionals seeking possibilities for advancing cancer care through science and innovation and collaboration is increasing worldwide. I'm also delighted to introduce our moderator for today's session, Dr. Rajni Verma, a respected professor with vast experience in medical physics and radiation safety. Dr. Rajni Verma is currently working as assistant professor at the Department of Radiological Physics, SMS Medical College and Hospital, Jaipur, India. She has received PhD under the Faculty of Medical from Rajasthan University of Health Sciences, Jaipur. Dr. Rajni Verma's professional roles include membership of Women Group, IOMP. She is also website manager of EFOM, executive committee member of AMPI-NC, editorial board member, SCMPCR newsletter. She is also member, board of studies at IIS University, Jaipur, India, and she also is radiation safety expert at the government of Rajasthan state. Research interest of Professor Verma is brachytherapy physics, radiation dosimetry, radiation protection. She also serves as a reviewer for several international journals, such as Physica Medica, Health and Technology journals. And now, Professor Verma, the floor is yours. Please also to mention regarding the tremendous global response of this event. Today's session has over 1,000 registered participants from all countries worldwide, for many countries worldwide. And this audience includes all professionals, radiation oncologists, medical physicists, dosimetrists, radiologists, radiation therapists, researchers. This means that the number of professionals seeking possibilities for advancing cancer care through science and innovation and collaboration is increasing worldwide. I'm also delighted to introduce our moderator for today's session, Dr. Rajni Verma, a respected professor with vast experience in medical physics and radiation safety. Dr. Rajni Verma is currently working as assistant professor at the Department of Radiological Physics, SMS Medical College and Hospital, Jaipur, India. She has received PhD under the Faculty of Medical from Rajasthan University of Health Sciences, Jaipur. Dr. Rajni Verma's professional roles include membership of Women Group, IOMP. She is also editor, website manager of EFOM, executive committee member of AMPI-NC, editorial board member, SCMPCR newsletter. She is also member, board of studies at IIS University, Jaipur, India, and she also is radiation safety expert at the government of Rajasthan state. Research interest of Professor Verma is brachytherapy physics, radiation dosimetry, radiation protection. She also serves as a reviewer for several international journals, such as Physica Medica, Health and Technology, and Health and Technology journals. And now, Professor Verma, the floor is yours.
Thank you so much for such a warm and elaborative introduction. I'll take it from now. Hello everyone. I'm your moderator for today's program. So today we are celebrating or commemorating World Radiotherapy Awareness Day, which was on September 7, 2025. And as a special guest today, we have Dr. Katie Wackham from UK, I guess. Yes, it's from UK. And we have Professor Arun Chougule as a main speaker of the day. So I will introduce Dr. Katie Home. Before that, I'll invite Jubairul Islam, founder and the executive director of GAMPER, for the introductory speech. Jubairul, are you there?
Yes.
Yeah, please.
Thank you. Good morning, good afternoon, and good evening, distinguished speakers, colleagues, and my dear participants. It's truly an honor to welcome you all the special GAMPER webinar held in the celebration of the very first World Radiotherapy Awareness Day 2025. This day is deeply symbolic. It marks the anniversary of the first patient treated with linear accelerator, a milestone that forever transformed cancer care. But beyond the history, World Radiotherapy Awareness Day is about the future, ensuring that radiotherapy is accessible, safe, and equitable for every patient everywhere. The global theme this year, One Voice for Radiotherapy, reminds us that while our language and cultures may differ, our mission is to save lives through the greater awareness, stronger education, and deeper collaborations. Radiotherapy is much more than technology. It's hope, healing, and often the only chance for cure for millions of patients with cancers. Yet we know that there are still many challenges: lack of awareness among the public, misconception about the radiations, and limited access to the treatment in low and middle income countries. At GAMPER, We are committed to addressing the challenge. Our mission is to build a stronger capacity in medical physics and radiotherapy through education, training, and research. We focus especially on LMICs where the need is greatest and resources are limited. Through our initiative, continuous education program, collaboration research project, and knowledge sharing platforms, we strive to empower professional, enhance treatment quality, and reduce global inequalities in cancer care. In the near future, we are also launching a mentorship program designed to guide and support young medical physicists and radiation professionals in low and middle income countries, helping them grow as leaders in their field. I want to take this moment to extend my sincere gratitude to our distinguished speaker, special guest, moderator, and all of the participants who have joined us across the globe. Your presence reflects the true spirit of collaborations, many voices, but on missions, advancing radiotherapy for safer tomorrow. As we celebrate the first World Radiotherapy Awareness Day, let us commit not only the learning and exchange idea, but also to taking the actions. So together we can build a future where radiotherapy is recognized, valued, and available to who all need. Thank you.
Thank you so much, Jubilul. Indeed, it's a great initiative towards the affordable and easy accessible knowledge for all. And I'm sure that it's going to be grown to a big platform for knowledge sharing. So now we are fortunate enough to have Dr. Katie Wickham with us. So Dr. Katie Wickham is an UK NHS-based clinical oncology consultant with an extensive experience in global cancer care. She currently serves as a co-chair of World Radiotherapy Awareness Day, WRAD, a world initiative promoting access to the radiotherapy for all patients, and is a co-lead of the mentorship program linking radiotherapy professionals in the NHS with colleagues at the Uganda Cancer Institute to strengthen skills and knowledge exchange. In 2004 and 5, Dr. Wickham worked as a clinician in a government hospital with the Hospice Africa Uganda, gaining early experience in cancer care in resource-limited settings. From 2007 to 13, she was based at MRC Uganda unit, first as a clinical trial coordinator and later as a PhD fellow investigating cancers and oncogenic infections. From 2021 to 23, she served as a section head of radiotherapy at International Atomic Energy Agency (IAEA), leading projects to improve access to radiotherapy services in low and middle income countries. Her work reflects a strong commitment to global oncology, mentorship, and advancing radiotherapy access across the diverse healthcare settings. We welcome you, Dr. Katie Wickham, and we are really fortunate to have somebody so closely associated with the World Radiotherapy Awareness Day today. So I welcome you once again. I invite you for your speech. Yeah. Dr. Katie Wickham, can you hear us? Kindly unmute yourself.
Oh, sorry, it wouldn't let me unmute myself, but you've obviously given me controls now. Thank you. Sorry about that slight delay. It's an absolute honor to be here. Thank you so much for inviting me. And, a huge thank you to GAMPER and your sort of wider supporters and team for supporting World Radiotherapy Awareness Day around the 7th of September on social media. We're sort of immensely grateful. So I'll just, I'll move on to my talk. I've got about 5 minutes just to really sort of talk about World Radiotherapy Awareness Day and what I hope that we can all do moving into the future to support the project, or the movement, I should say. So yeah, I'm a clinical oncologist. I'm based in London, and co-chair World Radiotherapy Awareness Day. We all know that radiotherapy is vital for curing cancer, alleviating symptoms, and improving patients' quality of life. But sadly, access to radiotherapy is not equitable, and there are vast parts of the world that have very poor access. The reasons for this include inadequate services, geographical barriers, insufficient workforce, and a lack of awareness of modern radiotherapy. And one way to try and overcome these disparities is to create an awareness day, which provides a platform for the community to join together and direct the attention of the public, media, and governments on the importance of radiotherapy. So the objectives of RAD are fourfold. The first is to raise awareness about the role of radiotherapy as a cancer treatment. The second is to highlight the global need to improve access to radiotherapy. The third is to educate healthcare professionals, patients, and policymakers about the importance of radiotherapy. And last but not least is to recognise the importance of radiotherapy professions, including the need for an adequate skilled workforce. I'm sure that we've all been in settings where we talk about radiotherapy and no one really understands, be that the surgeons that we work with or the patients that we meet or the policymakers that we come in contact with. We just get this sense that nobody really understands what radiotherapy is or really understands not only what we do, but why it is absolutely vital that everybody who needs it has access to it. So in terms of who can join, we've really concentrated in this foundation year on radiotherapy societies. And we hope to move forward going into next year with patient groups, interprofessional groups, industry partners, to really sort of focus the movement. But really, when it comes down to who should join, then probably the best answer is everybody. So cancer is getting more common. It's approaching 1 in 2 people here in the UK. And this means that access to radiotherapy is becoming increasingly important. So about half of adults and up to a third of children diagnosed with cancer should receive radiotherapy as part of their cancer pathway. We've made progress in this, but we have lots more work to be able to achieve this. Next slide, please. So going on to the planning events. So we announced the concept of World Radiotherapy Awareness Day, or RAD, in November 24 at London Global Cancer Week. And we had a planning meeting in March where we announced information about the logo, the theme, and the campaign messages. We've been really overwhelmed by the support, and we've had major endorsement from the major professional bodies around the world, including Elatro, Aortic, Astro, CACA, Caro, Estro, Faro, Mestro, PROS, the RCR, and SIOP. And it's really, really important that movements and projects like GAMPER are part of that sort of group of professionals that are supporting RAD going forward. Next slide, please. So as mentioned, the date that was chosen is the 7th of September because this is a landmark date for radiotherapy. So the first patient was treated in 1953 on the world's first dedicated medical linear accelerator. And this to us, when we were talking about choosing dates, represented the start of the modern era of radiotherapy and the quality and safety of treatment that everybody should expect. Next slide, please. So in terms of the logo, this was developed through feedback and voting rounds from supporters. So it represents a connected global community. People might see the lines slightly differently. They are sort of based around stylized isodose lines, but also showing the unity of our voices with sound waves spreading out around the world. The next slide, please. So our overarching campaign message or theme is one voice for radiotherapy. And I loved what was mentioned in the introduction about how, we all have different languages and come from different cultures, but we're all sort of striving for the same thing, and that's access to radiotherapy for all of our patients, no matter where they live. And we have a number of slogans, all starting with sort of one voice and really putting forward the patient, curing cancer, raising awareness, having a well-educated, skilled radiotherapy team, and a sort of a one voice for sort of cost-effective access to radiotherapy worldwide. We have started some translations for these that you can see on our website. And if anybody is keen to come forward with other translations, we'd be really happy to support translating our material into those languages and having those on our website for everybody to use. Next slide, please. So as many of you may be aware, we have, sorry, back one slide if that's okay. We've launched the website, and we have on that website, and that QR code takes you to the website. We have news articles, we have information about RAD events. So you would have seen, if you'd looked, this event is advertised there. We have all of our supporter logos, which includes GAMPER, and we have a resource toolkit that contains logos and posters and banners and event ideas. So next slide, please. So what we're asking everyone to do is to show the sort of the size and the strength of the community. So we had, a lot of activity around the 7th of September, but it's really important to note this isn't just a one-time event on one day. This is sort of a movement that needs to grow and keep going. So please do join us as a partner, follow us on social media. Those social media links will stay open and active all the way up until the 7th of September next year and then onwards. Please promote RAD through your networks, any media links that you have. Please contact us to post on our website any information on news articles or testimonials that you might have. And please think about events. So these might be in your workplace. We've had lots of cake sales, we've had walks, we've had people giving talks or grand rounds. Locally, I ran an event where I took our multidisciplinary team, so in particular the surgeons that I work with, down into the basement to see what LMICs look like, to start sort of spreading that knowledge amongst other healthcare professionals. If you have any society meetings coming up, please let us go. We will be at Aortic in Tunisia in November, also at CACA in China in Kunming, also in November. There's a team at Astro, which I think is next week or the week after. So lots of society events coming up with RAD sessions. So the slide shows some of those events that have taken place, a kind of tour of a LINAC. We've had walks in Tanzania and Namibia, and a number of webinars. So lots kind of going on and lots happening throughout the year. Next slide, please. So just that QR code again, which will take us to your website, to the RAD website. There is the website address, and you can see on the website you can access all of our social media sites. So please start posting. And just last slide, please. So just again that QR code that goes to the website. And just a really big thank you for everybody who's supported radiotherapy, everyone who's listened today and moving forward, everyone who's going to join. We really believe that one voice for radiotherapy from the whole radiotherapy community will make World Radiotherapy Awareness Day a success. And that's important because that is part of the drive to make a difference to people with cancer with radiotherapy. So thank you.
Thank you so much, Dr. Bekham. It's really great to hear you, and we really appreciate your efforts in cancer awareness, even for the LMIC and LIC countries. And indeed, radiotherapy is a very important part of cancer care. But because of economic viability, sometimes it's difficult. Even it is an essential part. Sometimes it is even difficult to provide such kind of services to the in these LMIC and LIC countries. We are really hopeful that our combined efforts will definitely bring a significant change in such kind of services to these economically low part of the world. So thank you so much for joining us and give us so much information about the Awareness Day. So now I'm moving forward with the program. So now we are going to our main speaker of the day, Professor Arun Chougule. Professor Arun Chougule is a well-known name in radiotherapy and medical physics. He's a pioneer in his field. But for the people who are new to this webinar, I'm gonna introduce him formally. So he's a Dean and Chief Academic Officer of Swasth Kalyan Group India. He was an ex-senior professor in Department of Radiological Physics, SMS Medical College Hospitals, and he's an ex-Pro Vice Chancellor of Rajasthan University of Health Sciences. Professor Arun Chougule has served as a chair of Education and Training Committee and the chairman and is the chairman of Accreditation Board of IOMP, is a member of Board of Directors of IMPCB, and an immediate past president of AFOM. He has published over 182 research papers in peer-reviewed journals and has presented more than 450 papers at conference worldwide. He also has been a principal investigator for 5 major government India-funded research projects. There are numerous honors to his names. He has many distinguished awards, namely IOMP IDMP Award 2016, AFOM Member Excellent Presentation Award, Outstanding Faculty Award at SMS. Then Dr. Farooq Abdullah Sher-e-Kashmir Best Researcher Award in 2012. And AFOM Outstanding Medical Physicist Award 2020. He's been granted a lot of fellowship out of honor. Some of them are fellow of IOMP, fellow of NAMS. And I should mention that this year, Professor Chougule has been awarded with the fellowship of IUPACM, and it's going to be awarded in IUPACM 2025 Adelaide, Australia. So we definitely congratulate Sir on this, as it's a very prestigious fellowship to be received by somebody from Asia. He is also a recipient of various prestigious fellowships, including IRCTT, UICC, ESTRO, Belair, ICTP, TWAS UNESCO, TWAS CAS, DART, and a regular associateship of ICTP. So without wasting any time, I am inviting Professor Chougule among us for the talk of the day. So, please.
Okay. Good morning, good afternoon, and good evening as the place you are in. Thank you very much, Dr. Rajni Verma, for the kind introduction. Thanks to GAMPER for giving this opportunity to speak on the occasion of World International Radiotherapy Awareness Day. And fortunately, we have Kathy here. She is spearheading this movement. So I'll be talking on precision with protection, radiotherapy for a safer tomorrow. Everything has been talked about. Greetings on the World Radiotherapy Awareness Day. This is commemorating the 7th September 1953, the first radiotherapy patient treated with linear accelerator, and a new era into radiotherapy treatment has started, and we are celebrating this as a day and the following week also. I will divide my talk into 6 sections. Ionizing radiation, its hazards, incidence of cancer, advances in radiotherapy, radiation accidents and lessons learned, radiation safety, advanced technique, there is a IMRT as an example I have taken, and time permit, I will go into detail or I will just run through quickly to the slides, and the safety culture required for the professional who are using the ionizing radiation in healthcare in various parts. So as you know very well, just after the discovery of X-ray on 8th November 1895, within few weeks, it was put to diagnosis, and within 3 months, it was put to radiotherapy by Emile Grubbe on 27th March 1896. So in last 124 years, medical application, ionizing radiation, not only X-rays, discovery of radioactivity, artificial radioactivity. We are using ionizing radiation in radio diagnosis and imaging. It has become a part and parcel of all the imaging procedure. Radiation oncology, that is a cancer treatment, nuclear medicine, cardiology, gastroenterology, urology, orthopedics, neurology, and many branches of the medicine are using ionizing radiation for diagnosis as well as for the treatment. And this is the categorization. If you take medical exposure categorization, diagnostic radiology, it can be conventional, computer, interventional, nuclear medicine, it can be diagnostic, it can be molecular therapy, and then radiation therapy. United Nations Scientific Committee on Effect of Atomic Radiation UNSCARE studies the effect of ionizing radiation and publishes the report. 2020-21 report, according to UNSCARE, 4.2 billion total annual number of radiological procedure. That means for a world population of around 8 billion, every second person is undergoing a radiological procedure. How essential. And also you see 6.2 million courses of radiation therapy treatment for a cancer we are having. So there's a huge application, growing application of ionizing radiation for diagnosis as well as a treatment. You cannot imagine the healthcare without use of ionizing radiation for diagnosis and treatment. However, ionizing radiation has the radiological effect, the health hazard, if they are not used appropriately. And these effects have come to known within few years for application of radiation. And just briefly, because I see in the audience, many are young students of medical physics, the early career medical physicists. So just I will be having little basic also. Somatic effect and genetic effect we have seen. Stochastic effect, the effect which do not have the threshold and they can start with the whatever small amount of dose, such as leukemia, induction of cancer, genetic effects and all. And the effects are classified as non-stochastic effect, where there is a threshold rhythmic effect, so that are called as after certain radiation dose only they can start appearing, such as a cataract, sterility. But depending upon the stochastic effect, no dose is a safe dose, and always we have to take a precaution. The use of the application radiation in healthcare must be justified, because radiation health effects are there. It can cause a lethal effect, sublethal effect, or even it can cause an aberration, chromosomal aberration, genetic effects, and they are there. So ionizing radiation is a double-edged sword. If it is not used cautiously, it is not used without proper training and proper understanding, it can do harm. And therefore, understanding about it. So basic principle of radiation protection are, first and foremost, is principle of justification. I will explain what is that. Principle of optimization and principle of limitation. So justification means every thing which is going to have risk and benefit, try to assess risk and benefit. So benefits outweigh the risk, do that procedure, let it be diagnostic or therapy. It's going to benefit more than the risk or the harm. Optimize as low as reasonably achievable. establish and use of diagnostic reference level for diagnostic application of radiation, dose constraint in research, optimization of the practical aspect, how you can bring down the radiation doses in diagnosis, in therapy, I will discuss in detail, and dose constraint for comfort and carriers. This is because ionizing radiation can cause a lethal effect, it can cause death, it can cause cancer, it can cause skin burn, it can cause cataract, it can cause infertility, and it can cause genetic effects. So it should be used with precaution, with caution. And for the occupational worker, that is the people who are occupationally using ionizing radiation, the dose limit by the ICRP recommendation are coming down and down from 500, that time it was not millisievert, but I can convert to millisievert, in 1931 to 1990, 20 millisievert, and no dose is a safe dose concept we are bringing with all weightage factors and all which are changing, because Unscare is giving new data. Based on this data, ICRP recommendation does. And if you see ICRP 60, 1990 report, gonads were the most sensitive, but today it is a breast which is most sensitive organ. So we have to think of the critical organ. And when we are treating in radiotherapy, where we are delivering very high doses, organ at risk, critical organ doses, that is very, very important. Excess radiation can catch you unaware, because unfortunately our human sensory organ cannot sense the radiation. Eyes cannot see, nose cannot smell, we cannot hear, we cannot taste, or we cannot feel the radiation. So we have to be very, very cautious. And therefore, we have external radiation, we can internal radiation in nuclear medicine, other. How you can protect from this hazard. One is distance. As inverse square law, more the distance, less the radiation is going to reach. Maximize the distance. Shielding, use the construction shielding, and also we use other shielding which are mobile barrier, lead apron, lead goggles, and other things. And short lead radioisotope you can store and then delay and then release, so that reduces the intensity. Now, this was a brief about the ionizing radiation and its health hazard. It can be a separate talk, but I have to be specific about the safety awareness about the radiotherapy. Incidence of cancer, the second point I'm going to discuss, is that if you look at the Globacon report, cancer is a second killing disease. And today, at every year in the world, about 20 million new cancer cases are found. And if you look at Asia and Oceania, 50% of the cancer, they occur in this Asia, Oceania region. And this is increasing every year. Incidence of the cancer is increasing day by day. Cancer is a leading cause of the death. And therefore, we have to diagnose. First thing, we have to prevent, diagnose at an early stage, and then treat them. So cancer is the second leading cause of the death, and almost 10 million deaths every year globally. 1 in 6 deaths, that is, I told you, 13% or more, are because of the cancer. Approximately 70% of deaths occur in the middle income and low middle income countries. And Kathy was talking about this being in IAE also, that disparity, and a lot of programs IAE started, Ray of Hope, to the countries where these facilities are not available, mostly in Africa and the Latin America regions where no sufficient cancer treatment facilities are available. Around 1/3 of the deaths from cancer are due to 5 leading behavioral dietary causes. I will not go into that thing which are there. And especially this region of Asia, where tobacco consumption is very, very high, almost 22% of the cancer are because of the tobacco consumption. You can treat the cancer by surgery, the medical oncology, that is a chemotherapy, and radiotherapy. More than 60% of the cancer do need radiotherapy either singularly or in combination with surgery, chemotherapy, or in consonance with that thing. So 60% of the patient, they need radiotherapy. As I said, radiotherapy has started just in 4 months of discovery of X-ray initially, and then we have got radioactivity and radium and all other radioactive materials started being used. The naturally occurring and artificially cobalt and other things, they came into use, and then the linear accelerator in 1953. So since 1896, in 124 years, there are huge advances in radiotherapy. And in 41 years of my career, I see we have to catch up this all advances, try to apply, keep on learning. So medical physicists, radiation oncologists, RTP, whoever is involved in this field, education, training is ongoing process. The primary aim of radiation oncology or radiotherapy is the deliver a lethal dose to the tumor. And I just said, radiation is a double-edged sword. Our aim is not only delivering a lethal dose in the tumor, simultaneously, we want to spare the normal tissue and organ at risk. So how to achieve this? This is an art, this is a science, this is a technology, this is a knowledge, this is a skill, and that is what we all, the professionals, are here to gain knowledge, improve our skills and ability. And now we have evidence-based, tailor-made treatment available so that we are delivering the lethal ablative doses in the tumor and sparing the normal tissue. So from 2D to 3D to IMRT to IGRT, the journey is going on, and now we have flash therapy, particle therapies, and all those things. Similarly, simultaneously with the introduction of ionizing radiation in diagnosis advanced very fastly, and we started using physical stimulatory in 1960s. CT imaging was introduced by Hounsfield and Cormack in 1971. Again, it was in Britain, in London, near London, CT 1971. At Exon Morley Hospital, first CT scanner was installed. Then we brought this CT simulator in 1980s for radiotherapy planning. We had MRI, then we have the combination, that is a fusion imaging, hybrid imaging, PET CT, PET MRI, then 4D CT. We have the ultrasound from 2D to 3D to 4D, now from physical imaging to biological imaging, and quantitative information for precision radiation oncology, radiogenomics, and oncology, radiomics, what we are using quantitative. So there is always a technological advancement in imaging, which has been also used into radiotherapy, and various treatment modalities from 2D to 3D. Multi-lip collimators have been introduced. Special technique like IMRT, intensity modulated radiotherapy, has been introduced. Stereotactic radiotherapy, image-guided radiotherapy, image-guided adaptive radiotherapy, IMAT, VMAT, machines like tomotherapy, scan, plan, treat, cyberknife, proton, carbon ion. So what we have got, all these gadgets to fight against emperor of diseases, the cancer. So we are evolving, we are treating, and over the years, cure rate of radiotherapy has gone from 20% to 80 to 90% also. And with this all imaging and advanced technologies, if you look at 1935, because that time we are using only a deep therapy or 300 or 400 kV X-ray machine, no cobalt machine was also there. So maximum dose delivery to the tumor was 40K, because the dose to surrounding normal tissue. Integral dose was very, very high. Then we have got a cobalt 60 machine, 1951 Pascal. We increased dose to 60 gray because of its energy, skin fairing effect, and all those things. Linac, we could still increase to 70 gray. Then Linac 3D CRT, conformal therapy with imaging and all those things. Computer treatment planning system 76 gray or 80 gray, Linac IMRT 80 gray, 84 gray, 100 gray carbon. This is the biological dose. Physical dose will be hardly 20 to 30 gray will be giving. So you can see with this advanced technologies, we are able to increase the dose to the tumor. At the same time, this technology is putting a lot of burden on QA/QC because we have to take almost care that if we miss the target and we deliver high doses to the normal tissue we are going to do the harm. The present day radiotherapy has shifted from population-based, one size, one this thing, to personalized radiotherapy, individual plan, image-guided radiotherapy plan adaptation as required during the treatment, shrinkage of the tumor, the position changing that we are going to image and adapt our treatment accordingly. So there's a huge revolution into treatment, and that is the World Radiotherapy Awareness Day. I've taken this thing, radiotherapy. What you need to know is radiotherapy contributes to nearly half of the all cancer cures. Very important thing. Over 200 million people, Katie has talked about, with no access to radiotherapy, even in African countries, Latin America, because as an accreditation program, I travel a lot, and in Asian countries, we have seen children are not being able to get the treatment and all those things. So we are seeing that we need to enhance the treatment facilities, and because they are expensive things, and because. So if you look at radiotherapy cancer care facilities in high income countries, for 120,000 people, we have one radiotherapy center, but low income, 5 million are served with a single radiotherapy machine, long waiting list, people may not get the treatment and all. Now, as I said, radiation is hazardous. Radiation can cause health hazard. And then human being, yes, will make errors. But learning from the errors, rectifying them, and precautionary measure, that is what is a human is. Now, this is the Agency of Healthcare Research and Quality report, how hazardous healthcare is. You can see, because healthcare, if you see mounting, climbing, bumping, this is very high. This is because of maybe wrong treatment, wrong medicine, overuse of the technology, overuse of medicine and all. And there comes also the radiation, health hazard, accidents, and all those things. So quality health service should encompass all these components. It should be timely. Delay in cancer treatment, the case which was treatable, curable, will go into advanced stage. It should be safe, it should be effective, it should be efficient, it should be integrated with all the facilities, equitable, people-centered. So this is the aim and objective of quality health. We all are human, incidents can happen, accidents can happen, but we can learn from them. Good quality assurance and independent checks can minimize the probability of an accident. Accident can be reduced. At the same time, severity of the accident can be brought down. Incident reporting is an essential part of the safety culture and affords an opportunity to learn from others' experience. And I will talk about this thing. There are in-country, international incidents reporting from where we can get the data, we can learn, and we do not commit the same mistake or the things which have been already done. As the radiotherapy techniques get more complex, prospective risk management system is needed. And therefore, right from the CTV countering, many publications are there that there are guidelines are not there, they are not being followed, lack of training, peer review, starts from PTV, and then we end up and marking of where and all. So potential for accidents in radiotherapy. Radiotherapy is a complex process, involves many steps between different professionals because it is a multidisciplinary, multi-professional teamwork. Radiation oncologists are involved, medical physicists are involved, dosimetrists are involved, radiotherapy technologists are involved. Not only that, diagnosis which is coming, that is also there. So human ear, a therapeutic treatment was delivered to a wrong patient, it can happen. A therapeutic treatment was delivered to a wrong treatment site. A therapeutic treatment was delivered with a substantially different dose or dose fractionation prescribed by the medical practitioner. It can happen. Equipment can malfunction, and therefore preventive and the check should be there. There will be failure of the machines and this thing after repair. Stringent QA/QC, daily QA/QC, weekly QA/QC, all. So prevent accidents radiotherapy, we can learn from previously occurred. Accident can be prevented by applying several safety layers of preventive action. The IAEA has defined what is incident. Any unintended event, including operating errors, equipment failure, initiating the procedure, near misses, mishaps, which are not negligible for point of protection of the safety, they are incident. Reportable incident, an incident of which the significance is large enough that it must be reported to the authority. And actual incident, the Arfos event has affected the treatment to the patient. Potential incidents, near misses, because we have QA/QC, we have supervision, checking and all, and then we can find, oh yeah, this is what has been done and this need to be corrected, and then we correct before the treatment has started. So errors in radiotherapy contributing factors, if you look at all this procedure, the instrument counts only 5%. So 90% are human errors. It happens because of the human error. And therefore, one has to take care of the education, knowledge, skill, and competency. And you can see insufficient education, lack of procedure and protocol as part of comprehensive QA program. Or that is not there, SOP is not there, or we bypass because of the more workload or time constraint or wrong. Lack of supervision of compliance with a QA program. So that always we say who has planned, checked, verified, and then we approve. Team is involved. Lack of training for unusual situations are there. We should keep it. Lack of safety culture. And you know, every accident has been studied in depth, and the investigation report, what was happened, what needs to be done to avoid similar kind of accident are published by IAEA. IAEA published many safety series, safety standards, radiation protection, safety radiation sources, international basic safety standard, safety reports of IAEA, lesson learned from accidental exposure in radiotherapy. ICRP also publishes report, publication if you say prevention of accident exposure to patient under radiation therapy, IAEA safety standard, radiation protection and safety in medical use of application, SHG 40, a lot of publication, lot of material freely available on the IVMP website. They are happening. So we have to keep continuing learning and practicing. Ensure the staff understand the properties and the limitation of the equipment they are using. Include in quality assurance program inter-comparison with the other hospital, independent checks, and that is what all we call quality audit. So we have to done audit, and IAL also has suggested audits equipment by independent group, independent equipment before equipment is clinically used, or after repair again we are going to use, or any new protocol we are going to start, we have to first understand all. Patient, not only equipment, because IMRT, IGRT, we have patient-specific QA are very, very important. Stay alert if you see unexpected behavior. This is from RTT, medical physicists, radiation oncologists, because they observe, because patient follow-up. And if, for example, radiation is given for brain tumor, if the hair loss some side, something that, those things you can observe oncologists, then talk to the physicists, RTT, see that anything is going wrong or everything is perfect or not. Independent recalculation would only work if that plan is pushed through for the treatment and not from the TPS plan, treatment plan. Working with awareness and alertness. Accidental exposure have occurred owing to lack of attention to the details, lack of alertness, and lack of awareness. Worse, if personnel have to work in a condition prone to distractions are there, then you have overlooked the things, and then lack of attention can happen. So accidental exposure have occurred when there is a lack of procedures and checks, or when they are not comprehensively documented or fully implemented. So always and always have a SOP, follow that SOP, and always training and so accidental exposure have occurred when there is a lack of qualified and well-trained staff. So that's always we see that proper education. And when we say medical physicists or oncologists or RTT, it is not just the knowledge. We have to have residency, that is the skills, and then competency. Very, very important. Responsibilities, accident exposure have occurred when there are gaps and ambiguities in function of a personal and lines of authority responsibility, and then blame game start. I was not supposed to do, I have not been told, I am not responsible. So those attitudes. So it is a combined responsibility and clear demarcation of the response is there. Workload, high workload and insufficient number of staff have contributed to accident exposure, and that is how, depending upon the type of treatment, complexity of the treatment, IAEA has brought out the guidelines, how much full-time staff is required, and that's what we have to comply. Many countries, there's a shortage of manpower, overloaded, and you cannot comply with all this QA, QC, and procedure. Actions where potential deviation from intended dose and geometry can be found before the first irradiation fraction of the patient, because at least we practice first day, first patient, first treatment, we all oncologists, medical physicists, the RTTs, everyone there, patient setup, all those things are verified properly, and how they can be. Action where deviation can be found during or after the treatment course need to be done. Application of safety technology, safety procedure, where contributing factors such as staffing levels and structure training, we have to do that. Any new protocol, any new machine, the staff, and it is not the one, all the team member collectively, radiation oncologists, medical physicists, artery, they must undergo a training on the new protocol, which are going to new machine, new procedure. That's a very, very important. Departmental leadership, that has to be important for patient safety. Teamwork is crucial for ensuring safe radiation therapy program, and additional equipment, personal procedure for safety must be available, must be used. So departmental member must trust each other, cooperation. Administration must provide strong support for safety. It is not that many times it happens that the demand, requirement for the staff, for the safety equipment, or the overload of the work is administration overlooks that thing. So support of that is very, very important. Even tracking, review, investigation, follow up for events and near misses is very, very important to learn from that. Appropriately qualified personnel and ongoing training, as I said, radiotherapy, technology are changing, improving. So we need ongoing training. Use of that can be by attending workshop, conferences like this webinars, many other things, reading the reports, literature. Use of standard operating procedure has to be there. Defined roles and responsibility team, and I will show a tablet format where response is what medical physicists, radiation oncologists, RTT need to do. Strong communication among the team member, continuous quality improvement. Nothing is perfect. So staff is adequately trained, adequately qualified, and has the equipment, understand operating procedure, set up incident learning system, no blame policy, regular feedback to the staff, encourage question queries. Different type of incident learning systems are there. Internal reporting system, in department, in hospital, in state country, and external reporting system, reporting outside organization, web-based, and as I said, Saffron, you must be knowing all this, IAEA, this is their safety reporting and learning system for radiotherapy where you can report any accident, anything have happened, and also learn from the data which is available already in the system. Similarly, this ASTRO and AAPM has brought out this role list is a patient safety reporting and serves national incident, build awareness, track and analyze internal incident while contributing to the national database, receive institutional specific summary report, receive newsletter and all. So this role is also this TG100 of AAPM. If you see all these things right from diagnosis, imaging and diagnosis, patient database, immobilization and positioning, CT simulation to imaging, transfer images, initial, all these chart fitting successful treatment. They have given the precaution, rules, things so that the failure doesn't repeat or happens analysis. And as you know, all you must be knowing as a medical physicist that the flow of this treatment, radiotherapy treatment planning and delivery is starts from image acquisition, image data import, registration, body contour, target delineation, and this is very, very important. And there you must have protocol, you must have learning, uniformity, constraints, those constraints, beam setup, then clinical structure drawing, normal tissue drawing, all these things has to be done, beam setup, constraint after that. Then dose optimization, leap motion, algorithm selection, dose calculation, plan evaluation, documentation of that is very important, and then approval of the plan, patient specific way, and then the patient treatment. This is all. Now, radiotherapy or any radiation department you are going to plan, I told you that the shielding, time, dose, and shielding. So shielding, structural shielding, because harmful effect of radiation is well established. The medical physicist is involved in planning, shielding, calculation, and adequate radiation shielding of wards, room, housing, radiotherapy, or any other radiation equipment sources need to be provided so that radiation exposure to the members as well public is kept below the dose limit. And therefore, I will not go into details of this thing, but there are guidelines, NCRP report 151, structural shielding design, evaluation for mega voltage X-rays, gamma radiotherapy available, IAEA safety report 47, talk about radiation protection design, radiotherapy facilities. Then this is McGill PH is there, IPEM is there, NCRP reports are there, they are available. So protective barriers, they are primary and secondary. I will not go into details of this thing because this is a linear accelerator machine, maze wall. These are for the floor, the roof, and these two walls. You can see the thickness primary, and always it's not that just the planning concern, but every year you have to check the radiation leakage outside around the thing for the safety. So secondary barriers, and there are limit permissible dose, country specific they are there. So you have to follow which country you are there and what the design limit for occupational radiation exposure. For public they are there, that is the instant radiation dose levels and the time average dose rate are limits. So just I give that thing. Now radiation safety in advanced technique. I talked to you that radiotherapy or radiation oncology from the inception in 1896 has come up 2D, 3D, advanced technique like intensity modulated therapy, image guided radiotherapy, adaptive radiotherapy, proton therapy. Now we have got the high dose radiotherapies, all are available. So as a one example, just I'm taking radiation safety in IMRT, which applies to all other things. So IMRT is a significant improvement in precise targeting of the tumor volume and sparing normal healthy tissue and OAR, and very widely being practiced. So IMRT offers significant clinical advantage. However, its complexity, number of fields, intensities, all various pitfalls and safety concerns also there. A systematic understanding of the likelihood and clinical impact of possible failures throughout a course of IMRT to produce maximum safety and quality of the patient care is very, very important before venturing, before starting IMRT. Entire team of radiation oncology, medical physicists, dosimetrists, RTTs must go through this thing. So implementation of IMRT comes with a unique safety consideration, must meticulously address to ensure protection of both patient as well as staff, because IMRT requires meticulous planning, rigorous quality assurance, comprehensive training for all involved staff, as I talked, all oncologists, radiation oncologists, medical peers. So adhering to safety consideration, optimize the therapeutic benefit of IMRT while safeguarding well-being of both patient and staff. That is what we have seen, the principle of radiation protection, risk and benefit. That is what. So safe and effective radiation therapy RT is extremely dependent on proper operation, application, and understanding of the technology and the procedure. So WHO radiotherapy risk profile that define all procedure that ensures consistency, because radiotherapy given in fraction every day of medical prescription, safe fulfillment of that prescription as regard to the dose to the target volume, together with minimal dose to the normal tissue, minimal exposure of personal, and adequate patient monitoring aimed at determining outcome of the treatment. That is what WHO radiotherapy risk profile. So IMRT technical consideration, if you see, establishing clinical IMRT planning, delivery protocol, perform commissioning on equipment, validate the accuracy of the treatment delivery parameter, evaluate the relationship between treatment plan parameters and QA. So very, very important is quality management, incident learning, standard operating procedure. They have to be in place, development of a proper safety culture, proper understanding of use equipment, and continuous education. So IMRT, the integral dose, because many fields, many beams you use, so large volume of the normal tissue, integral dose is increased. Low dose, still it is there. So even low doses of ion radiation may induce cancer damage. IMRT treatment requires 3 to 5 times more monitoring unit as compared to CRT, conformal therapy. Beam modulation increases the head leakage, MU per. Geographical misses can occur because we are tight margin, tight thing, disease recurrence. So there are challenges. IMRT is increase in total body radiation, greater MU results in increase of radiation scatter, radiation leakage that causes secondary malignancy. IMRT is a time-consuming, complex procedure. Its planning, delivery, quality assurance all requires sufficiently long time. So that is very, very important, is that you have well-trained, well-qualified the staff, sufficient staff, and then you can long treatment delivery time may influence also interfraction, motion, patient comfort, immobilization devices. They are very, very important. So these are reports. New York Times reported a serious accident involving both IMRT and other radiation treatment. This was in New Jersey, 36 cancer patient, Veterans Hospital were over-radiated, and 20 more received substandard treatment by medical team that lacked experience. The mistake, which have not been publicly reported, continued for months because the hospital had no system in place to catch the error. And that is what I was talking about. You have to put the system. So radiation offers new cures and ways to harm. That is the heading of the New York Times 2010. Technology surface, radiation lag. Another result, the process of care in radiation oncology refers to a conceptual framework for guaranteeing the appropriateness, quality, and safety of all patients treated with radiation for therapy. Many errors that occur in radiation oncology are not due to failure of the devices. 90% are human errors, and that is what we have to learn. And two approaches to do this thing is reactive approaches to safety and prospective approach. After accident happened, safety, these are the things. So there are pitfalls. I will not go into detail, just quickly I will trade treatment planning. Planning errors can be there, inadequate dose distribution, potential leading to suboptimal treatment outcome, geographical miss can be there, and then organ, that is accurate imaging, defining target, that is what I call CTV, that is very, very important. Imaging artifacts can be there, anatomic changes during the treatment or the treatment in with their tumor shrinkage, weight loss of the patient, all those things. Machine performance QA is very, very important. Preventive machine measurements and repairs also to build. Highly reliable treatment delivery system is important. Mechanical failure can happen. Calibration drift can occur. Energy variation. And as I was talking about the CTV and the OAR, this thing, head and neck, very, very heterogeneous thing, very difficult to take large number of CT images involved, and level of precision required in head and neck is very, very high. Patient positioning setup daily, that has to be there. Movement during treatment, quality assurance, rigorous and continuous quality assurance procedures are required. Inconsistent QA practice, variability in QA practice across different can lead to inconsistency in treatment quality. Then dosimetric challenges are there. Accuracy of dose calculation algorithms, what TPS use, what algorithms you use, and then tissue heterogeneity and the factors where commissioning errors, if happens, that will carry on for the treatment. So robust planning protocol, IMRT treatments are more sensitive to geometrical error compared with conventional 2D or 3D because of their higher dose conformity. Standardized procedures, SOP has to be there. Peer review process to catch and correct planning errors. That is what we make it. Review, checking, and then approval. Then multimodality imaging we are using, CT, PET, MRI, all this we are using. So improve target definition, adaptive planning, changes in patient anatomy or post-treatment should be there. Routine calibration, preventive maintenance, reduce the risk of mechanical failure, immobilization devices, stability of the immobilization devices, precision of the patient immobilization devices are very, very important. They should be comfortable at the same time. So these are many, many things we have to take. Day-to-day position changes in the target volume. Some cancers such as prostate, now bladder full, rectum full, all those things we have to take into account, because prostate you are going to treat, empty bladder full, there will be treat. So major challenges in treating tumor in cardiothoracic regions where movement, pancreas organ during treatment, adaptive treatment, interfraction, target position changes and setup error, and they can be minimized by the IGRT and all those things. So comprehensive QA program is very, very important. Regular QA checks, end-to-end testing with Phantom, verify the entire treatment delivery is very, very important. So a lot of job for a medical physicist dosimetry. Independent verification can enhance QA. So secondary dose calculations, and then this dose calculation, that plan has to be used. AAPM have given task group independent dose and MU verification for IMRT, the task group 219 report. Third party audit, and that IAE also suggests auditing of this thing. So very, very important accuracy. Staff training and education, ongoing training and education for staff are crucial. Initial training when you are going to have the new protocol, new machine, initial training for new staff members on the IMRT, ongoing education, simulation drills, QA drills. These are very, very important as a. So hazards in IMRT program categorized as environmental and also technical. So environmental concern affect all patient treatment, include the lack of SOP, HEST, habituation, incomplete understanding or misuse of the procedure, every patient. Technical concern include inadequate commissioning of the clinical IMRT program, inadequate validation of the accuracy of the treatment, and inadequate investigation of the discrepancy between the treatment. So, risk of secondary cancer, many publications, many reports have come up. So, because we are giving lot of outside the tumor volume because of the number of beam, the integral dose, and that is going to cause. Pediatric patient is there, very, very important, because children are more sensitive to radiation and they are going to live for longer time. And you can see younger the patient group, the attributable lifelong risk is very, very high. So you have to consider all these points in radiotherapy, stringent QA test, QA procedures are patient-specific, it has to be there. Verification of disease-specific treatment, field portal, important QA procedure for IMIT. EPID, electronic portal dosimetry system need to be, again, AAPM task group 307, the use of EPIDs for patient-specific IMRT and VMAT QA are there. So all reports are available. And that I was telling, task responsibilities, all tasks, everyone is involved. You see a dosimetric expert, the radiation oncologist, medical physicist, and then you see the responsibilities of the physicist, verify correct version of the patient treatment plan approved. All these I have marked. So every responsibilities of your team, therapist, the second therapist, physicist, second medical physicist to review. This is a very, very important that all these things have to be reviewed, and then approval system. So safety culture, very important, safety culture, because as you know that radiation safety culture in the healthcare is a very, very important. And it can be with the professionals, it can be with the organization, with the space, it can be the manufacturers. So safety culture, the stakeholders or manufacturers of the machine vendors, international organizations like IOMP, AAPM, all these professional societies, medical educators, policy makers, regulatory bodies, research agencies, radiation protection experts. And if you talk about the professional radiological medical practitioner, medical physicists, health physicists, referral, all are stakeholder in radiation safety culture. It is mindset. Radiation culture is a mindset. So radiation safety culture encompasses patient exposure and occupational exposure. And medical physicist has a job of radiation safety officer, radiation protection expert, and many times he is understood as a wrong perception that the medical physicist or radiation protection officer is a hindrance in the task in the hand because they ask documentation expertise, but they are helping the reduce the patient exposure, occupational exposure. Implementing the principle of justification, optimization is essential to ensure that radiation used in healthcare is managed safely because benefits are more. So positive safety culture, the real building block, safety, trust, communication, and the culture. And therefore, safety culture in the different part of the country is different. It depends upon culture, education, social, economic, and many things. So, as I said, 95% of the errors are because of the man or woman behind the machine, behind the protocol, and the machine only work for 5%. So, leadership responsibility, individual responsibility, continuous learning, effective safety communication, respectful work environment, problem identification and resolution, environment for raising concern, decision making, question attitude, and work process need to be there. So benefit of radiation safety cultures are there, that it addresses radiation safety of all those involved in the healthcare applications of radiation, including patients, staff, and public in general. So patient safety and quality should be embedded in radiation safety in healthcare by defining prevention of errors, learning from any errors that have occurred, building on a culture of safety that involves healthcare professional, organization, and patient. And just WHO 2008 published radiotherapy risk profile, and it says 3,125 patients were reported to be affected by radiotherapy incident between 1976 to 2007. About 1% of the affected patients died due to radiation toxicity overdose. More than 4,500 near misses were reported in literature in year 1990 to 2007. Unscare in 2010 completed comprehensive review of accident involving ionizing radiation exposure from 1945 to 2007, and they have reported that highest number of fatalities 46 deaths and highest number of acute injuries 623 resulted from accident related to medical use of ionizing radiation. And this actual number is likely to be higher because many are not reported. That culture is not there. 2014, IRPA published guidelines, and these guidelines give visibility to fundamental of radiation protection, science and value, promote radiation risk awareness, promote shared responsibility among practitioners, operators, managers, regulators, maintain the radiation protection heritage and facilitate its transmission, improve the quality and effectiveness of radiation protection. Anyone with a safety concern or perceived safety concern should be empowered to raise awareness, resolve the issue, before commencing the activity. And there is a one call of action which was supported by IAEA WHO 2014. And you look out of 10 objective, 8 is strengthen radiation safety culture in healthcare. And little bit I talk about this action. A, establish patient safety as a strategic priority in medical uses of ionic radiation, recognize leadership as a crucial element of strengthening radiation safety, closer cooperation between regulatory bodies, health authorities, professional societies, cooperation between different disciplines of medical radiations, very important, learn about best practices, support integrated radiation protection aspect, health technology assessment, work towards recognizing medical wages independent professionals. Those all are action 8. So everyone can participate in strengthening radiation safety, local initiatives to help care providers improve safety in the facility, specific training focused on radiation safety culture, training on new radiation generating equipment, routine update training on radiation safety issues, the knowledge, new knowledge which we get, inclusion of radiation safety culture in conferences, sessions like what we are doing, IUMP is doing, AAPM is doing, many organizations they are doing. AAPM also provide guidelines, develop this effective checklist for all those things for addressing radiation safety culture. IRFA guidelines also are there about radiation safety culture. So comprehensive, the competence of the health professional, focus on radiation protection training, knowledge, skills, and attitude. They are very, very important. The competence is defined as the ability to do something successfully or efficiently and included acquiring needed knowledge, theoretical skills, and practical and attitude. They are very, very important. So academic education, clinical training, professional recognition, and maintaining competence, CPD, they are very, very important. Always remember, safety is first. And with that motto, we are there. We can make this precision radiation oncology, all this application of radiation in healthcare more beneficial, reducing the harm. It's on our hand by acquiring knowledge, skills, competence. Education is a passport to the future, for tomorrow belong to those who prepare for it, and that competency is very, very important. Thank you very much for your patience sharing. Thank you very much for the opportunity. I got this thing. Any queries are there, I will be happy to answer. Thank you very much.
Thank you so much, sir, for a wonderful talk on radiotherapy practices and the physics associated along with radiation safety. Your insights were not only highly informative, but also inspiring. The clarity with which you explained the concepts and highlighted their importance in patient care and professional practices, this made a session truly valuable. Now we are moving forward to the question and answer session of the program. So should I start
Yeah,
with
sure.
questions? Yeah.
No.
So we have first question, which is, does a patient have a dose limit? For example, in case of reoccurrence, and do we have any need to repeat the radiotherapy?
See, re-irradiation. There is no consensus yet what dose. It all depend upon, because see, we know that LQ model with that thing, we can assess there is a gap between the treatment or patient has come with a recurrence after a gap of 6 months or 1 year. We can estimate, we can calculate the biological effect remaining, how much dose can be given. But ultimate dose fraction, how much should be given, will be a clinical judgment by the oncologist, depending upon the patient conditions, the organ at risk, age, and many factors. There are consortium of European Union, ISRO and all, they are working on re-irradiation, what doses, what fractionation schedule should be there, but there is no uniformity, no consensus. In daily practice, we come across with this thing. Even patient do not take the treatment complete, goes away, comes back, and we try. We use LQ model, try to give, but they are guiding. Finally, it's a clinical judgment. We do that.
Thank you, sir. Indeed, beautifully explained. And this is, of course, this was a very important question. We face it in the daily practices. Now,
Yeah.
moving towards the second question, it is, do we have any law for the radiation worker? To best of my understanding, he means maybe a dose limit for the radiation worker.
Yes. See, every ICRP has given the dose limits for radiation workers. We have the 20 millisievert per year. Then for cornea, from 150 to 50, it has been brought to 20 millisievert. Every national regulatory authority, they generally follow ICRP guidelines, but there are some variation depending upon the situation, and there are guidelines for occupational radiation worker. The radiation doses received must be monitored either by film batch, not it's absolute, TLD, OSLD, they should be monitored, they should be kept as low as reasonably achievable, they should not exceed the dose limit prescribed by the agencies. They are there.
Thank you so much, sir, for highlighting this again. Now we are moving to our fourth question, which is from a PhD student, Imane from Morocco. His question is, can the secondary radiation from flash radiotherapy cause serious consequences in the present or in the future? And are there studies about this? And he's also thanking you for the talk.
Okay. Flash radiotherapy is a very new upcoming. Some clinical trials have happened. It has not come as a routine treatment yet because of the dose rate required, 40 gray per second machines and things. So very limited superficial tumor. So secondary cancer, secondary radiation, it cannot happen in a day or two, latent period is 10 to 20 years. So first thing, the flash therapy has to become in practice, and then the latent period has to go, and then only we'll find some of it. But anything, secondary radiation, the off-field radiation is prone to cause secondary malignancy. That is for sure.
Thank you so much, sir, for explaining this. Now we are moving to our next question. The question is, why does a 2-gray dose cause more apoptosis? And why is 2-gray dose used clinically? For our viewers, apoptosis means an excessive rate of programmed cell death. So, sir, on your remarks on this.
See, this 2 gray per fraction conventional radiotherapy, we started Coutard and Regard in 1920s, 30s. But now we have moved from conventional fractionation to hypofractionation, extreme hypofractionation, single fractionation. So it depends upon the radiosensitivity of the tumor. And you know, alpha by beta for prostate cancer, for breast cancer, for head and neck cancer. Depending upon this radiosensitivity, dose per fraction, number of fractionation, total fraction, it is dose per fraction, number of fraction, total dose is guided by the radiobiology, cancer biology, the sensitivity, and multiple factors. It is not just a standard 2 gray per fraction.
Okay, thank you so much, sir. Leading to another question. So we have a question which is, considering the unique advantage of helium ions, such as their sharper Bragg peak and reduced lateral scattering compared to protons, what are the main clinical challenges and limitations that currently prevent helium ion therapy from being widely implemented in treatment centers?
Okay. Protons, because of its mass charge, still easy to accelerate, and you can have a compact accelerators which can be put into the hospital. Larger ions, larger mass, to accelerate them, to make them energy, this thing, we need very big accelerators. So these are the disadvantages as part of accelerating the particle heavy ions very this thing. That is what carbonyl. So you see we are able to do that, but very limited institutions they are able to do, and the cost is also very, very heavy because accelerator required that kind of thing to rotate and generate that energy. Similarly, the RBE of every particle things, how they go, how they deposit, that is very, very important to study. So these are some of the limitations. There can be many, many ions are in research, but actually using in clinical practice, many things are involved. Feasibility, accessibility, cost, benefit, risk. That because of that thing, helium has not yet been proved its worth.
Thank you, sir. We have another interesting question. Is there any way we can measure LMIC output in real time during treatment?
Yes, why not? Real-time treatment, one is you have dosimeter, you have EPID, other things you have. See, there are dosimeters, if you take it, one is accumulated and you can read. Online, you have the semiconductor detectors, put it continuously, you can monitor what doses, where doses are received. So that's possible. That's possible.
Thanks, sir. Another question is about why there is a difference between the radiation limits from UK, US, and India.
Oh, see now, just if I go ICRP, many countries follows ICRP 20 millisievert. US is still 50 millisievert. Okay. So again, the corneal doses were brought from 150 to 50 to 20. India still is 50 millisievert because implementation, just by bringing the things, is not make a rule, but is it implementable? So different country have their perception, their culture. As I told, radiation safety culture all depends upon the resources available, the culture, the philosophy, the regulations. So countries, UK, that's what good nicely has seen that thing. UK, just compared India, UK, and USA. Yeah, there are how much you can achieve.
Thanks, sir. We have a lot of questions. I hope it's okay with you, sir. So we have a next question, which is
it will be okay, job role, because time limit, I don't know. I don't know.
No, sir, please.
Yeah, the next question was on what basis the limits are implemented, but I think this question is thoroughly answered in the presentation, so I will move forward to next one. So the next question was a situational question, which says, suppose that some worker got a high dose accidentally. What does he or she do to reduce the risk?
Okay. Now, there are actually regulations that sometimes also, you will see ICRP recommendation, 20 millisievert averaged over 5 years every year. Total dose in 5 years is 100 millisievert. But any 1 year, 30 millisievert. Even sometimes, for example, accident happened. For example, Fukushima happened. Some worker have to go and they may get higher radiation dose. Simply. So they have to be kept away from further radiation work so that this 5 years 100 millisievert is not exceeded. So it is not that 20 millisievert means every year you cannot exceed in 1 year. It can be 30. Sometimes situational, even 50 millisievert.
Thank you so much, sir. The next question is from our lovely host, Maya. She wants to ask regarding the treatment breast cancer using IMRT and increasing, it is increasing secondary cancer risk if we go for IMRT for breast cancer treatment?
Yeah, there are multiple reports and even our reports are there that if you increase this, the number of fields, scatter radiation doses, contralateral breast, the cancer incidence. Not only that, also patient have been reported treatment of the breast cancer, esophageal cancer because of the transmission dose to the esophagus and this thing. So it is there, yes. But always again you see that radiation, we have to weigh the risk and benefit. We have a calculated risk, yes. We have to take that.
That is true, sir. And I also feel we should optimize the secondary dose while doing the IMRT. So it can definitely reduce the risk of secondary cancer while treating breast. So now we have
at the same time, you should not miss the tumor, underdosing. So this all balancing act, that's what I tell, art, science, technology. It's not a planning, it's just, it's a calculation, 5 plus 5 is 10. No, it's an art, how to give benefit. So we see, you as a physicist or as a thing we know, we generate many plans, many things, and then we weigh, okay, how the dosimetry, how doses, and then we choose a one plan. Even that thing, we in between again assess and we remodify our plan so that risks are not too much. At the same time, underdosing or we are not missing the tumor. So it is a very balancing act we have to do.
Definitely, sir. I could not agree more because when we are treating breast, it's very crucial. We have to look for the lung doses as well. They are also very sensitive. So we don't want to go for the lung toxicity and all those things. So, okay. So now finally moving towards our final question for the session today, sir. So the question is how the radiation is different technique of radiation, the dose value is increased. Okay, I think the participant want to ask with the conformal techniques, as we are moving from conventional to conformal techniques like IMRT, IGRT, we are increasing the dose which is given in the treatment. So how do we, when the value of dose is increased, how we take care of the OARs?
See, with the imaging technologies, what we have got, earlier we had only CT we are using, so we used to give only the anatomical imaging. But now we are using PET CT, MR PET, MR LINAC we have got. So we are able to delineate OAR very, very precisely. We are able to confirm the conformative index of the target, and then because of that thing we are able to give. Why earlier with a square field we are not able to go more than 50 or 60? We could have given it, but at the same time normal tissue would have got the comorbidity very high. Now the normal tissue or OAR portion is very, very less involved. And therefore, we are able to give escalate the dose. So more the better the conformity, better the ablative dose we can put into the tumor. And this is how our imaging techniques are able to give. And now I said quantitative imaging also. So quantitative imaging, not only homogeneous dose into the tumor, hyperactive lesion, more doses, filled in field log, like this, we are able to treat that thing.
Thank you so much, sir. That's true. That is the crux of today's presentation, as we are talking about precision. So with precision and conformity, we can move towards the higher doses. And of course, the motto of radiotherapy, like maximum dose to the tumor and the minimum to OARs, is something we want to achieve with the higher precision and conformity. So with this, we have come to the end of our question and answer session. So, sir, thank you so much for this wonderful talk. We have many comments in this section. They are really happy with the presentation, and few of them want to have you as your PhD guide. So I must mention that I was fortunate enough to have him as my PhD guide. So so it was great. So indeed, I wish best for them. And for any specific question, you can write to Professor Chougule directly. And of course, GAMPER team is also working on having this presentation on YouTube and Facebook. You can access their website for the further details. And about the certificates, the link is also shared in the chat box for having a certificate. So kindly do check the chat box and use the link for the certificate. I think sir wants to say something.
Yeah. Initially, I just wanted to say good afternoon, good evening, but I saw from Venezuela Professor Jesus also in the audience. And then I said it's a good morning in Venezuela. So all this. So across. So thanks to GAMPER, see, we have audiences across the world. One thing. Another thing, I saw many young students, young medical physicists and all, they are there. See, in our mythology and this thing, we say after 61 prastasham, that is, now you give back to the society. We have taken a lot from the society. And if I can give education, training, the most happy person I will be there. So please contact me for any kind of educational support, help, material thing, any PPTs, even this PPT if you want, I am happy to share with any one of you. So if it benefits for upgradation, that is what we are humans here. So I'll be very, very thankful to guide you within the resources what I have with me. I will be supportive because I'm also in the GAMPER. So the very good initiative, very good thing. So at least patient. And I have sought more than 250 participants here. Very nice across the world. Thank you.
Thank you so much, sir. I should take this opportunity to thank all of them. Our lovely host, Maya, my bright colleague from Bangladesh, Jubairul, of course, the founding member, founding person of this initiative, Dr. Beckham. And last but not the least, our active participants who have joined us from all around the world. And of course, the whole GAMPER team for providing me the opportunity to moderate the program and bringing this wonderful program for everybody. So now I give the podium to Maya or maybe a Jubairul to formally wind up the program for today. Thank you so much.
Thank you so much. It is really, really very pity this session is ending. Professor Chougule, it is really very interesting. I'm very impressed and I want to say great thanks. It was really very impressive, very significant. And all comprehensive aspects, we as a people working with ionization radiation, we have to know, now we know. And if you don't manage to say everything, you gave us all links, where can we refer to improve our knowledge and to find our answers. So it was really very impressive. Thank you so much.
Thank you.
Also, I want to say thank you to our special guests who introduced us regarding this interesting event, WRAD. Also our moderator, who made great efforts, everything to go so smoothly and so well arranged. To healthcare oncology, which is a valuable scientific partner of GAMPER in our work. Also, great thanks to Sriram Rajurkar, who is GAMPER member and did great effort for this event to be held. And also great thanks to our participants who are interested, who are participating, take part, and who want to improve their knowledge and to know much in this field. Regarding recordings, it also was mentioned in the chat box, and that will be available on webpage. And also, I hope people manage to find the link and complete it to get certificates, because for who manage this, the certificates will be distributed shortly. And finally, I want to say that this our webinars will, of course, continue, and about the next one we will inform and announce in short period of time. I will again take this possibility, and as always, GAMPER advises us, and it is very useful, advice to all our participants to share this information through the local network, because we found from this impressive presentation, we saw so significant regional and national disparities persist in the world. And if we increase our awareness of radiotherapy, if we increase for the people to know its importance in the treatment for cancer patients, and also if locally or globally we widen collaboration markers, we will save or improve lives of our patients. So share this information, involve more people. This will be very beneficial for our cancer patients. Great thanks, and hope to see you again in the closest future.
Thank you, sir.
Thank you.
Goodbye.
Bye. Good night. And of course, good afternoons who are in the mornings. Okay, bye.
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 Thank you.